Next we've got Sidney Chandrasiri from Epworth Healthcare, and Sydney's going to be talking to us about leading the transformation in value-based healthcare. Thank you, Sydney.
Okay, thank you very much, Chris. Good morning, everybody, and thank you for turning up to this presentation. I've just come back from San Francisco and Arizona, having had value-based discussions, so I'm going to try to adapt the American context where I can. However, if I start talking nonsensical, please forgive me, I'm going to blame the jet lag. Okay, I'm going to start with a quote by Dr. Jan Kimpen. Jan said, "Given the unmet potential and pressing need to make healthcare more sustainable, we must seek out and experiment with innovative payments that share the risk and align incentives across care pathways and providers." What Jan's talking about is value, but where does this concept of value really come from? Now, we've seen in this morning's presentations the equation, outcomes over cost equals value, but it really all began in 2006 with the work of Michael Porter and Elizabeth Teisberg when they looked at the dysfunctional structure of healthcare. And what they found was that competition was set up in a way that it ended up being a zero-sum competition. And what that means is when you have gains in one part of the healthcare system, it's often at the expense of another, which is why we've got providers and funders really working on their own self-interests, and why we have this concept of cost shifting in our healthcare system. What they proposed was to restructure the healthcare system to have it incentivized in a way that we align the goals, we align the stakeholders to have a common goal. So what exactly is value-based healthcare? Well, in the most fundamental sense, it's a model of delivering healthcare. It's about improving health outcomes and improving the experience of patients against a lowered cost of delivering these outcomes. Now, during my time in the States, what I've come to realize is that average performance of our health services is not going to be enough. We're going to have to ramp up our performance, because it's the top performers, the top providers that have the better outcomes who are going to earn a disproportionate share of the market in the future. Which is why we need to take a systems view and an integrated view into value-based healthcare. So it's not about individual clinicians or administrators working harder or better in silos. And we've got to take a long-term view, which means look at the value of the care of over the full care pathway of the patient, as opposed to a single episode. I want to emphasize that value creation is not about cost reduction, because if it was the case, then we would end up simply paying less for ineffective care. And value creation is not just about quality improvement either. If you look at hand hygiene compliance, I'm sure we all rigorously monitor hand hygiene compliance, but if we're not actually reducing the hospital-acquired infections, then what's the point? Value is created when we decrease unwarranted variation, we've already seen that, and value is created when we increase efficiencies, which is better resource usage. So in the States, they have a term for this, they call it resource stewardship, which is a benign way of really saying cost reductions. But I do want to emphasize that it's not about cost reduction alone, the focus has to be on reforming outcomes. So transformation is coming. Why do we need it? Well, we've all seen healthcare expenditure is unsustainable. In Australia, we're at 10% GDP in expenditure. In America, they're at 20%. We've got an ageing population and an increasing burden of chronic disease. We've got health inequalities in access across geographical areas and within population groups. And the MBS review has highlighted that we're investing in non-evidence-based care. There's already a funding shift starting from reducing reimbursements and health funds and governments imposing penalty payments. And the recent media coverage around out-of-pocket costs is another reason why we need to look at value. And then the value proposition of private health insurance, which I'm sure you've seen in the media lately, really gives us another reason as to why we need to go down this path. There's also emerging disruptors. Artificial intelligence is all the rage, but we need to have value-based approaches to this. Robotic surgery, for those of us who have robots, and Epworth has 6 of them. We're grappling with the challenge between cost and the evidence. We're seeing changed care models from overnight surgery to daycare, and increasingly home-based care models, as well as digitization and increasing health consumerism, where our patients are expecting instant care. when the focus is on value over volume, quality and patient engagement increases and financial risk lowers. So what happens is it benefits every single stakeholder in the healthcare system. I'm going to talk very quickly about some value generating strategies about how we actually implement this. So there's this concept of super specialization centres. You would have heard this also referred to as centres of excellence. What we're trying to do with these is to build volume-related expertise, to decrease low-value care, decrease unwarranted variation, and improve the efficiency in complex care delivery. If we take, and another value-generating strategy is to take a prevention or population health focus. And the reason for doing this is to reduce the high costs of acute hospital admissions. And then we also need to look at care coordination, which is about navigating our patients through the multiple complexity of our current health system and tracking their overall well-being from a holistic perspective. And we need to look at expanding the scope of precision medicine to actually individualising the treatments for patients so that it generates value for them individually and for the populations. And we need to explore the cost of time-driven activity-based costing. There was a question this morning about how can we use activity-based costing to implement value-based care. And this is really a methodology which will allow us to more accurately cost the care that we're delivering. And what that does is it actually costs per minute the usage of each resource. So every minute a doctor spends with a patient or a nurse spends with the patient, it's actually costed. Oh, this is stuck. Predictive analytics, we really need this to identify the patient segments for which we can embed value-based care principles. And we need to have active disinvestment in low-value care, which we've already seen. We have to achieve process efficiency and decrease supply chain variation. That's a way of generating value. And we fundamentally need to have shared responsibility and shared financial risk between providers and funders if we are to achieve value-generating strategies. Very quickly about value-based care pricing. There needs to be a complete shift in our mindset and approach to how we contract and fund healthcare in Australia. We need to move from fee-for-service contracts to performance-based contracts. And one method of incentivising this funding model is that of bundled payment models. So when payers and providers share this financial risk, they both get incentivised to achieve all those things, which is what we want. We briefly touched this morning about enablers of healthcare. So we need to have interoperable IT infrastructure to be able to share data and to share outcomes. And we need to have value-driven performance accountabilities, which means our reimbursements need to be aligned with value outcomes. And we need to actually look at the workforce capability that we have, which might mean having to redistribute the roles, responsibilities that we have now, and have a new mindset in terms of the cultural approach to this. There is fundamental traits in terms of leadership that's needed to lead this transformation. Now, from the organisations in the US that have done this successfully, they found these 4 leadership personas are what was instrumental in successfully leading value-based healthcare. Now, from my perspective, and in the Australian context, I think this persona of dyad leadership is really resonates, because we need to have our health insurers and our governments working collaboratively with our public and private providers to create value, to align their goals to value. And my personal favourite is the leadership persona of value evangelists, which are those leaders that challenge the status quo, those that inspire us to overcome resistance and skepticism to change, and really to adapt what our communities and our patients need of us in adapting value-based healthcare. So from a practical perspective, these are I think are the key concepts of how we're going to embed value-based healthcare. Let's all start measuring outcomes. Let's all start measuring costs, accurate costs of what it's actually costing us to provide healthcare today. Let's start thinking about how we can integrate the care that we deliver now. And let's start thinking about how we can embed some of the value-generating strategies that I've spoken about. And then we can look at collaborating with funders towards value-based funding and contracting models. And then the next practical step is to obviously evaluate, use the feedback, and expand the value-based models that we're going to put in place. But most importantly, we need to collaborate and engage with our clinicians throughout this process. So this is all theoretical, and I fully acknowledge that. In terms of looking at how this can work in the real world, I'm going to start telling you a story. So I'd like to introduce you to Sylvie and Kirby. Sylvie and Kirby are two retired adults about to start their journey through the healthcare system. Sylvie lives in the world we know today. Kirby, on the other hand, lives in the world of the future with a true value-based healthcare system. Sylvie and Kirby have been experiencing long-term hip pain. Conservative management has been tried and failed, and hip replacement surgery is now being considered. Sylvie is referred to a hospital near her home. The hospital has favourable patient experience reports, proudly displayed on its website. Unfortunately, it also has high readmission rates and performs only a limited number of hip replacements per year. Readmission rate is the only quality metric measured by the surgical unit of this hospital, and this data is not shared with the public. In contrast, Kirby and his primary care physician consult a website that compares hip replacement outcomes across all hospitals in the country. A hospital located an hour away is highly ranked with low readmission rates and scores highly on patient-reported mobility post-surgery. So this hospital is chosen for Kirby. During the pre-op assessment, Sylvie cannot remember the full list of medications she's on. This forces the surgeon to have to chase up her doctors and go through multiple administrative obstacles to obtain this information. This delays the scheduling of Sylvie's surgery by a week. Kirby's surgeon asks for his consent to access his electronic medical record. The hospital IT system is linked with others in the region, allowing the surgeon to quickly gather Kirby's medical history from previous visits. In choosing a prosthesis for the operation, Sylvie's surgeon selects a prosthesis that he's been working with in recent years and with which he is the most comfortable operating. For Kirby, on the other hand, a multidisciplinary team, including a surgeon, a geriatrician, and a physiotherapist, discuss his mobility goals together. Using decision support tools and noting that Kirby is a devoted cyclist, they agree on the best prosthesis. Kirby's surgeon then books the surgery with a colleague who has outstanding mobility outcomes with the chosen device. Sylvie and Kirby have their operations. Unfortunately, both their post-operative journeys get complicated when they contract an infection at the surgical site. So both are now required to undergo a second surgery to replace the prosthesis. Time for discharge arrives. Sylvie's hospital operates under a fee for reimbursement plan. Sylvie is required to pay a $4,000 out-of-pocket payment, while her insurance pays an additional $6,000. Kirby's surgery was charged at a bundled payment rate. It included the cost of all interventions associated with his hip replacement, beginning with his pre-op appointment and including the second operation. At Kirby's hospital, the financial incentive to reduce post-operative infection is strong, and his infection was a rare exception. Sylvie's medical staff assumes that her rehabilitation spot will remain available even after the delay from the second surgery. Unfortunately, the bed is given to another patient. Sylvie is sent home after one extra day on the ward. However, she faints soon after coming home and returns to the hospital emergency room. Her stay is extended by another 5 days. In Kirby's case, the rehab centre was immediately alerted to ensure a spot is kept available. His medical team understands the importance of coordinating early rehabilitation. A delay has high chances of delaying the surgical outcome, for which the surgeon is responsible. Because Kirby's bundled payment includes the rehab cost and is linked to patient outcomes, it incentivises the surgical department to collaborate closely with the rehab unit throughout his care. Kirby's rehabilitation is successful and he's able to begin cycling at 6 weeks post-op. Sylvie's experience, we have to note, is not the product of bad intentions, but the result of rational responses to the complex rules and incentives that have evolved over decades in our health system, leading to negative unintended consequences. A focus on value can transform Sylvie's story into Kirby's. To do so, we need a truly patient-centric healthcare system that starts with measuring health outcomes and combines informatics with key enablers in a supportive public policy environment. This will lead us to create an evolutionary health system where outcome transparency allows us to learn from systems around the world, identifying best practices and eliminating wasteful spending that does not create value. This is the future of healthcare. This is value-based healthcare. Now, you'll recall that I started with a quote. I'd like to end my presentation also with a quote. It may seem a perilous and uncertain future that is descending upon us, but as custodians of Australia's healthcare system, it is imperative that we seize this opportunity before us. The time is now, and we have what it takes to forge a new path, an integrated and value-based path. You might be wondering who said these profound words. It was me. I said it.